about that. Any questions or any concerns or worries?
Would you like the concerns?
In alphabetical or order of priority.
Well, you picked the wrong person.
So let's, this over here, I just put the sympathetic nervous system up again, just as a review, because it's nice to be able to see that as comparison with the parasympathetic nervous system. Helps to compare and contrast. So the parasympathetic nervous system, you all will recall from your physiology days, is the brake or the counterbalance to the adrenergic system. So basically it keeps the adrenergic system in check. If we didn't have it, we would be all adrenerged.
So we're not doing chapter.
Oh, yeah, we didn't do that.
Hold on. Wrong one. Go to, sorry, get so excited. 20. Don't you want to start with blockers first and then? No, have to go in order, the way that it makes sense. All right, from the beginning. Yeah, there we go. Sorry. Nutty. All right. So just what I said, parasympathetic is the opposing system to the sympathetic nervous system. Just like we had multiple terminology for the same thing, sympathomimetic. This is parasympathomimetic, just PNS, same stuff. So the key neurotransmitter in the parasympathetic nervous system is which one? Which neurotransmitter? There's just one, that's the main one in the parasympathetic nervous system. Acetylcholine, abbreviated ACH. So that is the neurotransmitter at the preganglionic synapse and at the postganglionic. So we have acetylcholine both here and here, where before we may have had acetylcholine with then epi or acetylcholine then norepi. So we're dealing with acetylcholine. There's a 2-minute neuroscience link there for your enjoyment. That is another review that I won't go over. But I like to give you just some options of things that I think make sense to me when I'm listening to them. So if you don't know how the system works, it's hard to learn the drugs, right? All right, so we have direct acting and indirect acting. So here we go, we have a synapse here, we have a synaptic cleft, and we have the receptors. So we can have a drug that directly binds to the receptors and activates them. All right. Or we can have the same mechanism of action that we've had in other drugs, where we interfere with the enzyme that breaks down the neurotransmitter. So cholinesterase inhibitor, star, is a key term. So acetylcholinesterase is the enzyme. The result is more acetylcholine available, right? Everybody kind of remembers that if you interfere with the enzyme and breaking down a substance, then you have more of the substance available. Kind of like with dopamine, where we had drugs that interfered with the breakdown of dopamine in Parkinson's. Same idea. We either stimulate the postsynaptic neuron or a postsynaptic receptor, or we prevent the breakdown. All right. So the first one we look at are cholinesterase inhibitors. So cholinesterase is talking about ACE, anything that ends in ACE is an enzyme. So cholinesterase would be the enzyme that breaks down acetylcholine. So kind of learn the terminology, you can almost figure it out. So we can bind up the cholinesterase for a short period of time. We bind up the enzyme, leading to more acetylcholine available, or there's some irreversible ones. And they last longer because the body has to make new enzyme to break down acetylcholine. So these are shorter acting, and these are longer acting. All right, what do? Cholinergic drugs. So remember, this is the opposite of activating adrenergic receptors. This is the counterbalance to it. So if we activate the peripheral nervous, the parasympathetic nervous system with a cholinergic drug, we get the opposite. So we have decreased heart rate, right? We have decreased vasoconstriction, which is vasodilation. All right. That's the activity in the cardiovascular system. So if we act on the respiratory system, and where's my respiratory system? So what's the opposite of the adrenergic agonist activity, or stimulating the sympathetic nervous system? Well, in the sympathetic nervous system, we got bronchodilation. So by default, we know that the opposite is bronchoconstriction. This is why I tell you, if you learn this, you know everything else. All right, what's the next one we look at? All right. So we're going to go through the main systems that we're going to be talking about drugs that affect. So we had decreased GI motility, and let's see, increased gastric symptom, increased urinary frequency. So this one would decrease urinary frequency. Increase. That's the beta-3 where we use the mirabegron. So over here, we're going to have decreased GI activity. So basically, we have slower bowels, we have slower peristalsis, and we have increased what we really love to have, urinary frequency. All right. So if we want to constrict pupils, we might give a cholinergic drug. If we wanted to dilate a pupil, we might give an anticholinergic drug. They love to talk about pupils, even though it's probably the most minor thing. Increase pupil constriction. Okay. And then one of the key things they do is increase secretions. So they can be oral secretions, they can be your exocrine glands like sweating. Let's put oral / sweat. And that's important because there's times that we want to affect our secretions. So here's the one that we talk about that's a cholinergic drug. So a cholinergic drug promotes the parasympathetic or blocks the parasympathetic. A cholinergic drug. This is adrenergic. This is cholinergic. A cholinergic drug, does it promote activity or does it block activity? A cholinergic drug promotes. One that blocks would be an anticholinergic, right? So if we want to direct acting, reduce intraocular pressure, then this is the prototype drug that they talk about, pilocarpine. and it's topical. And we don't give it oral because it doesn't get absorbed well. It may or may not show up. It's not an important drug, but I know that it has shown up in exams before, even on a HESI. So we said, okay, pilocarpine is a topical cholinergic. Topical. So then we have oral. So if we want to promote movement of the bladder, suppose someone has undergone anesthesia and their bladder hasn't woken up yet, or someone has poor bladder tone. Well, we can increase the tone of the bladder and increase the motility. So this bethanechol is used to promote proper bladder functioning when the bladder has lost its tone for whatever reason. So all these meds are just positive cholinergics, positive cholinergics. They're cholinergic drugs that are promoting the normal activity of the parasympathetic nervous system by acting in some way on acetylcholine. So they're just promoting the normal activity of the parasympathetic nervous system. Let's see. So here's all the conditions: post-surgical apnea of the bladder, postpartum urinary retention, and a neurogenic bladder from anyone who has either a spinal cord lesion or a spinal cord disease or a spinal cord injury. And then the contraindications. So, and the reason why, especially in Parkinsonism, well, especially in cardiac disease, is we don't want extra stimulation. But either way, learn that this bethanechol, it's going to drive me crazy. It's call or chol, I think it's call, is used for apnea of the bladder. It is a cholinergic drug promoting the activity of the parasympathetic nervous system. So obviously, a drug that promotes acetylcholine would interfere with a drug, interact with a drug that breaks down, that inhibits. So, okay, let's do this. We have acetylcholine. So we have a drug that increases acetylcholine, and then we have another drug that prevents the breakdown of acetylcholine. So if you have this drug plus this drug, what happens to the levels of acetylcholine? Are they high, low, or balanced? High. If you have a drug that promotes acetylcholine and a drug that promotes acetylcholine, you can end up in a cholinergic crisis. Too much acetylcholine. So we have to be careful with what category of drugs our patients are on. All right, this is the direct acting one. We've seen it before. Succinylcholine. So it's an adjunct to general anesthesia. It is a ultra short acting cholinergic drug. Succinylcholine. No antidote. We know that in one of this problems with this one is that can cause hyperkalemia because of muscle fasciculations. So those muscle spasms and tightening and contracting and releasing can break down muscle tissue, and cells, when they are disrupted, release potassium. Potassium is an intracellular ion, and so when you release it from whatever the destruction is, it's in your serum now, and your potassium levels go up. So you have to be careful with hyperkalemia, because hyperkalemia can cause cardiac rhythm issues. So succinylcholine is a direct acting cholinergic. All right, now this is indirect acting, same idea. Here's the acetylcholinesterase, and here's the acetylcholinesterase inhibitor. So basically interfering with the enzyme that breaks down acetylcholine. I like this picture. It really gives it to me. So increases acetylcholine at the receptor site and cause contractions, causes skeletal muscle contraction. This keeps acetylcholine bound longer. All right, so what drugs are there? What drugs have acetylcholine? What drugs do we use? So, okay, so I think I put a video on here about myasthenia gravis. So that's the condition that we're gonna talk about. So myasthenia gravis is a condition where we have a breakdown of either the production of acetylcholine or the receptors for acetylcholine. And so we have loss of the ability for muscle contraction. And so, yeah, here it is, destructure of neuromuscular connection. So here's the normal neuromuscular connection with all these lovely places for neurotransmission. And here's this junction that has been destroyed by this disease. And so we can't get good transmission of that signal across the synaptic cleft. We've lost receptor sites. And so the drug that we use is one that prevents the breakdown of acetylcholine, right? It's an acetylcholinesterase inhibitor. It's the one over here with the little Pac-Man that binds on to the enzyme and keeps acetylcholine in this cleft for longer. If we can keep acetylcholine, the neurotransmitter, in the cleft longer, there's more likelihood it will have a chance to bind and signal the activation of muscles. So the key drug that we use for that is pyridostigmine. Just know this is a acetylcholinesterase inhibitor, right? So would we want to take pyridostigmine at the same time as we took this oral bethanechol for bladder atrophy? The answer is no, because this one is acetylcholine replacement, and this one is, the second one is prevents the breakdown of acetylcholine. You'd end up in a cholinergic crisis. So myasthenia gravis is a nasty little disease. The key teaching point on this one is to take the medication 30 minutes before you eat. Why does it even matter? Well, yeah, we need to get it into the system because you need muscle function in order to chew. So people with myasthenia gravis, they can start to chew and then they can't, because there's not good transmission through that synaptic cleft, the jaw will weaken dramatically in just a few minutes. So they need that medication in order just to eat. So that's kind of the key teaching about pyridostigmine. All right, this is the diagnostic drug. So if someone has these unusual presenting symptoms of like eye weakness, and these are some of the symptoms, early symptoms of myasthenia gravis, they would give edrophonium in order to diagnose it. And if the patient has a dramatic improvement in their muscular symptoms, when this drug is administered, that's diagnostic for myasthenia gravis. So pyridostigmine and edrophonium can show up. All right. So pyridostigmine, neostigmine, chrysostigmine, where have we seen neuromuscular blocking drugs? Way back in anesthetics and general anesthetics, neuromuscular blocking drugs. Well, for some reason, this book likes to talk about, and exams like to talk about, chemical warfare and organophosphates. So farm workers who may have had an exposure to organophosphates, these are the drugs that we use to reverse it. Neostigmine, pyridostigmine, physostigmine, never used it. The other ones I have. So just recognize, I hope that question doesn't come up. I can't remember if it did. All right, so that is the drugs that treat like myasthenia gravis, bladder atony, and yeah, those ones. Now there's a big section on Alzheimer's disease. So there's a lot of drugs on the market for Alzheimer's disease, and unfortunately, they're playing on patients and families' fears and beliefs that something's out there to cure the disease or to stop it from progressing. What we know about all the drugs that are marketed for Alzheimer's is that they are weakly effective at best. They were only studied for 1 year. On a functional scale of 0 to 100, they have this, steady group of patients in general. And they came up with a functional scale. And the average function on this scale of activities of daily living and IADLs, they came up with a scale of people with mild to moderate. The average was about 73 on a functional scale. And then they gave various drugs at various times in different studies to treat Alzheimer's. And what they found was that if any improvement, it was no more than 2 points on the scale, and which pretty much was, or more than that, was unnoticeable. So we get the unfortunate task of telling patients, reminding patients that dementia is an uncurable disease, is chronic and progressive, just like Parkinson's. There's no cure, and that the drugs that we have are weakly effective. The goal in therapy is just to stabilize any loss of cognitive function and maintain their ability to participate in ADLs for as long as we can. But they haven't been studied beyond 1 year, and they're really crappy drugs, and they have a lot of side effects. So these are some of the most common ones: donepezil, galantamine, rivastigmine. You should recognize the names, especially donepezil. So donepezil is also known as Aricept. It is a cholinesterase inhibitor. Again, another cholinesterase inhibitor. What disease did we just talk about that used a cholinesterase inhibitor? Myasthenia gravis. So we're using the same mechanism of action in preventing the breakdown of acetylcholine. These all have the same mechanism of action. So the thought is maybe if we increase acetylcholine, that we can stabilize the disease, sort of like giving L-DOPA in Parkinson's, and it's converted to dopamine. We're kind of hoping that we can stabilize the disease progression and stabilize function, but it's temporary. Sucks. One of the main adverse effects that I've seen with this one is GI upset, just nausea, vomiting, diarrhea. It can cause gastric ulcers. The big one is the GI upset. There are lots of effects on the cardiovascular system potentially that can include both bradycardia and tachycardia, hypotension or hypertension. Like I say, it's super complex, but the GI upset is the most common one. And then these are the most common interacting drugs: anticholinergics and NSAIDs. Right. So memantine is put in the book because it falls in the category of drugs that treat Alzheimer's, but it's not related to acetylcholine in any way. Kind of like how they put other drugs for Parkinson's that were not related to dopamine. So it's not a cholinergic drug. It's used for moderate to severe Alzheimer's. Again, short-term studies, minimal effect. Goal is to stabilize cognitive function, maintain quality of life. People with memory impairment who forget to take pills, it's a great option to have a 7-day patch. Problem is remembering to take it off. I remember when I was a home health nurse and I went to see a patient who was referred because they were complaining of terrible, GI side effects and diarrhea. And upon doing physical exam, there was a patch here, and a patch there, 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 and a patch there. All right, problem solved. So that's a problem when you leave the meds to someone who has progressively impaired cognitive function. Same potential adverse effect. The most common is the GI upset. Again, we have to be real with patients and families. When patients or families call and say, it's been a year and I don't see any difference in mom, or it's been a year and mom's getting worse, we get to say, guess what? It's a chronic progressive disease. What we know about these drugs is that they have little, if any, benefit, and we don't know if it benefits beyond a year. So oftentimes we would do a therapeutic trial off the medicine. It is a therapeutic trial. We don't call it stopping the med. We might back down on the med to see if the symptoms worsen. And if mom's cognition dramatically gets worse, well, then it was having some benefit. But most times people stop the drugs and nobody notices any difference. Here's the period of before you will see any potential benefit. 6 weeks, kind of like antidepressants. There's most things we're going to take a while. Anything that acts in the brain is going to take a while to see a therapeutic effect. So yeah, unfortunately. So when are cholinergic drugs contraindicated? So if we already have decreased if we have GI obstruction, we don't want to take a medicine that will decrease motility. So if you're already impaired, we don't want to take a drug that will slow it more. Parkinson's, contraindicated. COPD, epilepsy, hyperthyroidism, lots of reasons why they're contraindicated. And it will be explained when we looked at the adverse effects. So, like every other drug that I've said, the adverse effects are simply a result of the function of the drug. So just like in the adrenergics, just like in anything else, you may get one effect that you want. So say we wanted to decrease the heart rate, but perhaps the side effect that we don't want is to increase the urinary frequency. Or say we're taking that bepinetol to increase urinary frequency because we have an atonic bladder, but unfortunately we have a decreased heart rate and vasodilation. I pass out. So the adverse effects is just the undesired effect of the drug, the part that you don't want. So bradycardia, right? Bradycardia, hypotension. Increased bronchial secretions, bronchospasms. Over there we have bronchoconstriction. It's all just a function of what acetylcholine normally does. So here's the GI adverse effects, abdominal cramps, increased secretions, nausea and vomiting, diarrhea should be in there. Now here's a time where we actually do want one of the adverse effects. There's a disease called Sjogren's syndrome, which is the dysfunction of exocrine glands. And so they lack tears and sweat and saliva. So hey, might be great if we used a cholinergic drug to increase secretions and relieve that dryness. Get some increased tears in the eye, increased saliva in the oral mucosa. So hey, that's one time that this particular side effect is the desired effect, and all the rest of these are the undesired effects. All right, so what does a cholinergic crisis look like? So let's say that we combine a cholinergic drug with a cholinesterase inhibitor, and we got a lot of acetylcholine now and end up with a cholinergic crisis. So early signs, we have diarrhea, salivation, really, it's just all these symptoms on steroids. But if we end up with significant hypotension, we can end up in circulatory collapse and shock. Right? Bradycardia times, that's what he's reading. So he's urinating a lot, his heart rate slowed, he's got all kinds of secretions, he's sweating like crazy, his eyes are running, his nose are running, he's vomiting. That's the visual manifestation of a cholinergic crisis. So what do we treat it with? We talk about atropine, which is a cholinergic antagonist. So it's the opposite. Just like we had adrenergic agonists and adrenergic antagonists, we have cholinergic drugs and we have cholinergic blockers or cholinergic antagonists. So anytime we're suspicious of a cholinergic crisis, the treatment is atropine. Yes, know your antidotes. Let's see, what do they interact with? Anticholinergics, antihistamine. So anything that works against this mechanism of action. So if you're trying to promote urinary frequency by using this particular medicine, you don't want to take an anticholinergic in order to dry up your nasal secretions. So you can't take a cholinergic and an anticholinergic, right? You end up canceling each other out.
Is atropine the antidote for myasthenia gravis?
Myasthenia gravis is a disease where you lack acetylcholine.
So the medicine they take, that
Pyridostigmine.
is the atropine an antidote for that?
Well, if you ingested massive amounts for some reason and ended up in a cholinergic crisis, then that would be the antidote. What do they want you to know? They want you to know when we're talking about Alzheimer's and dementia, that ginkgo is the supplement that every little old person believes helps prevent memory loss. We know that it has a lot of drug interactions, including with NSAIDs and with warfarin and with some of our seizure medicines. So asking, hey, what are you taking for your memory? Nothing. What kind of herbal supplements? Nothing. Do you take ginkgo? Oh yeah, I thought you were talking about prescription meds. Every time. All right, we don't have time for that. So let's do some questions. The nurse is assessing a patient who has been taking a cholinergic drug, positive cholinergic drug for 3 days. They have flushed skin, orthostatic blood pressure changes, and are complaining of abdominal cramps and nausea. What are they likely experiencing? They have this. They have this.
Early signs.
Right, early signs of a cholinergic crisis. It's just the symptoms of acetylcholine activation, but on steroids, right? And so this is how it's supposed to be sludge. I think there's supposed to be a j. Sludge, salivation, lacrimation, urination, defecation. Yeah. The risk of the cholinergic crisis is going into shock, heart stopping. Kind of a big deal. All right, 60-year-old woman asked the nurse about taking ginkgo to help with her memory. She has arthritis, type 2 diabetes, thyroid disease, and hypertension. She's taking etodolac, which is an NSAID for arthritis, taking an oral anti-diabetic medication, thyroid hormone, and a beta blocker for blood pressure. What potential adverse effects from the ginkgo would be of most concern for this patient? They threw a lot in there. Lot in there.
I think bleeding because you have NSAIDs.
Yeah, I would agree that we've got, that's probably the most significant in there. Is that right? Yeah, bleeding. So the most significant would be in relation to an NSAID and GI bleeding. And even though we haven't talked about NSAIDs, the book talks about ginkgo and some of the drug interactions. Okay, the patient's scheduled to have lunch at noon. The nurse will administer pyridostigmine at what time for optimal therapeutic effect? So you have to say, first off, pyridostigmine is used to treat what condition? Pyridostigmine. Pyridostigmine. Oh. Myasthenia gravis, right? Cholinergic acetylcholinesterase inhibitor. Keeps acetylcholine around for longer. We said if we want to have lunch at noon, what time should we give the drug? Right? We give it 30 minutes ahead of time. So important nursing knowledge questions. Patient with Alzheimer's dementia accidentally took 2 weeks of a cholinergic medication. That happens. He's brought to the ED, he's going into shock, experiencing severe hypotension and vomiting. The nurse will expect admission. Which initial treatment? So what's the treatment for a cholinergic crisis? Right, that's what it's asking. Right, patient is being seen by a neuromuscular provider. In the past 4 months, he's had numerous blood tests and x-rays, and there's no diagnosis and no change in their symptoms. Their symptoms are muscle weakness, they're easily fatigued, difficulty chewing. Provider notes the left eyelid is drooping, and the provider believes he's reached the correct diagnosis. To confirm the diagnosis, they plan to administer edrophonium and expects the patient to respond with increased muscle strain. First off, what type of medication is edrophonium, and how would this medication provide a diagnosis? So what were all those symptoms of? What was this? Left eye weakness, muscle weakness, easily fatigued, difficulty chewing, symptoms of myasthenia gravis, right? And so edrophonium, if you recall, was the diagnostic medication for myasthenia gravis. So what would you expect to see if it was a positive diagnosis? Improvement in their muscular symptoms. What type of medication is it? Acetylcholinesterase inhibitor. Keeps acetylcholine around in the synaptic cleft for longer. That's what it is. What are the adverse effects of edrophonium? It's going to be the adverse effects of acetylcholinesterase inhibitors. So we can have hypertension, hypotension, bradycardia, tachycardia. Go figure, nausea, vomiting, GI upset. So it's all of these are just from an overstimulation of the parasympathetic nervous system. Adverse effects. The patient asks, how long will it take for the medication to be effective? This is the edrophonium. How long will it take for the edrophonium to be effective? Immediately. If you take this, your symptoms should improve immediately. That's why it's diagnostic. You should immediately have an increase in muscle strength because suddenly your acetylcholine is available for muscle contraction. All right, this is a different one. A neighbor, Jane, comes over and asks you to help her understand a new medication that her grandmother's taking for Alzheimer's. Jane isn't certain what acetylcholine is and asks, how is this affected by her grandmother's medication, donepezil? So how could you explain how donepezil works in layman's terms to Jane? Donepezil works on acetylcholine, which is a chemical in the brain that helps with signaling, right? This signaling is important with memory and thinking. So that's a simple way to explain it. Now, if we're talking to another nurse, we might say it's an indirectly acting cholinesterase inhibitor. Yeah, sure we would. Cholinesterase inhibitor. Jane knows that Alzheimer's is progressive and asks, how well does this donepezil work? And is there anything else we can do to save the memory? How well do these medications work? And we try and be optimistic. 15 to 30% perceive a benefit. It might be minor, but that's what the statistics say. Just because somebody doesn't respond to, so we start low, we go up on the drug after a period of time. If there's no benefits, it doesn't mean that we can't try out another drug in the same class or that we can't add on memantine. It's a lot of drugs for grandma to take. Jane wants to know if the cholinergic drugs have significant side effects and asks what you should watch for. What's the side effects? They're the activity of acetylcholine. So overstimulation of the parasympathetic nervous system. Hypertension, hypotension, tachycardia, bradycardia, abdominal cramp, salivation, flushing, nausea, vomiting, diarrhea. Just learn what the function of this is. You'll know what the adverse effects are. How about 36-year-old female who was diagnosed with myasthenia gravis 4 years ago. Unfortunately, myasthenia gravis has a predilection or preference for females. Sucks. She went recently through a divorce, has been under significant stress the last few months. She comes to the emergency department with sudden onset weakness, drooling, and an inability to articulate words. After the ABCs are stabilized, what history should the nurse gather? All right, so she's got some symptoms here: muscle weakness, drooling, inability. We worry about stroke for sure, but the myasthenia gravis is the key. We're working to gather information that would help us know if she's having a cholinergic crisis, including what over-the-counter medications might she have taken. Did she accidentally potentially double dose or forget that she took a dose and took it again because she couldn't remember? So to differentiate between an exacerbation and a cholinergic crisis, we administer pyridostigmine. Because if it's a cholinergic crisis, what will we administer? Starts with an A, atropine. So if she's having an exacerbation of myasthenia gravis, we would just give a little bit more of the pyridostigmine, the cholinesterase inhibitor that's typically used in myasthenia gravis. If she's having a cholinergic crisis, we're going to administer atropine. All right. Reversal agent, atropine. All right, that's that one. Take a break, and we will come back and do the cholinergic blockers, and then you will know everything.